to the, I think, 5th and final little video within the topic of antipsychotic medication. We've talked about first and second generation antipsychotics. We've talked about their side effects and their benefits. We've talked about clozapine, which is its own little class, although it is within the second generation antipsychotics. What we haven't talked about is the route of administration. So I've given you my little crib sheet. These are the routes. So we can give medication orally, either in a time of crisis because they cause quite a lot of sedation and cause someone to calm down, or in regular dosing. Antipsychotics have a pretty immediate effect. They're not like antidepressants that take a few weeks to build up in the blood before we see an effect. We usually give it to somebody either once or twice a day. They're often quite sedating, so we'll give them in the evening. And we start low, we go slow, we increase gently. But we can also give medication IM into the musculature, so a needle often into the bottom. We use that as little as we want, as we can get away with, because it's very uncomfortable. We usually use that in what we call rapid tranq or rapid tranquilization. That's if a patient is very agitated, usually on an inpatient ward for a mental health unit. And if someone's getting very agitated, we will get a syringe and we will fill it up with antipsychotic and we will inject it. We don't like doing that. It's very distressing for the patient, it's very distressing for the staff, but it does work quite well. So if someone's in a highly agitated state and we think they're at risk of harm to themselves or someone else, serious harm to themselves or someone else, then we will use a rapid tranquilization via IM. In that situation, if you can imagine someone being very distressed, running around, often really agitated, often quite scared, so they might be quite violent in a sort of defence way, then actually IM is much better than IV because we don't routinely have lines in our patients, access, so we don't have cannulas, and if they're an inpatient then we can monitor their SATs and we can monitor all of their vitals and we can keep an eye on them after we've given it so it feels as safe as it can be. The final route I want to talk about is depot medication. Really confusing, I hadn't heard of it until I did psychiatry. Essentially, depot is a long-acting injection, usually an antipsychotic. It releases slowly, so it means patients can have this injection once a month or once every 2 weeks or every 6 weeks. It's really, really good, so it slowly will release the antipsychotic. The benefits are they don't have to remember to take the medication. If someone is very bad at being compliant with their medication for all sorts of reasons, then we can agree with them that this is a nice compromise, that they only have to come in and have it every 6 weeks or so, don't have to remember. The downside is it can leave a lump in the bottom where we give it, so we try and alternate the side. But more importantly, if someone has an adverse reaction, you can't get it out. Once it's in, you can't get it out. So what we do is we give somebody, give them a trial and get them established on a medication orally, and then we'll slowly transfer it to depot. We do what's called a test dose first, so once we've got someone on the right dose for them, the right medication that works well orally, then we will titrate across to giving it as a depot instead, so we can be as sure as we can be that that will be safe. Because what we don't want is someone having a serious adverse reaction and us being able to not do anything about it for 6 weeks till it runs out. I hope that's covered antipsychotics in enough detail. I hope I haven't skimmed through it too quickly. Wikipedia is a really good source. I know I shouldn't say that, but do have a look for an overview on antipsychotics. This is my crib sheet, so maybe if you can read that, you can freeze it and use it as a basis for your revision. And good luck with your exams.